Hi guys, welcome to the Acute Medical Unit. The AMU is a resource-intensive unit that aims to expedite the process of diagnosis, definitive treatment, and disposition. There are 4 places a patient can go from the AMU. Home. About 50% of patients are discharged from the unit. Keep. Patients can be kept in the AMU for up to 3 days. This is for patients who anticipate a short stay or are awaiting investigations that might affect admitting specialty. Transfer. For patients needing inpatient rehab, AMU has a SLH fast track that can transfer patients the same day or the next day. For patients who do not require surgical or specialist review, they can be admitted to AH general wards. For patients who require inpatient palliation, they may be suitable for AH supportive care ward. This requires an NUH palliative care referral to assess for suitability. Finally, admission to a UMC subspecialty of your team's choice. This is usually the least preferred option due to the bid rate. Often during morning rounds, patients are not yet confirmed or KIV for discharge provided certain criteria are met. For example, if labs improve, scans are okay, temperature or symptoms resolve, and importantly, if PT clears. Now, the quicker patients leave the unit, the quicker patients enter. We like patients to leave early in the day so that new ones come in during office hours, avoiding a surge of 15 new admits to see during morning rounds. As you can see, many things are happening in the AMU and many people are involved. Therefore, communication and clear documentation are extremely important in the AMU. Let's go through the workflows special to the AMU. Labs. Only order labs that are sufficient. Don't order fasting labs. Non-fasting lipids and HbA1c are usually sufficient. All scans except X-rays and CT brains need to be called for. Call the on-call radiologist for CTs, and if approved, call the EMD radiographer as we use their machine to expedite scans. All procedures such as LPs or joint taps must be ordered and completed in Aurora for tracking. Changes like referrals, calling for scans and blues, discharges, updating the progress board should be done as rounds progress. For treatment, apart from medication, many of our patients need physiotherapy. Let's help them prioritize who to see first. First, there's no need to order OT. PTs will assess and refer if required. Now, don't order PT if patients are already walking around AMU, medically unfit for rehab, or already bid-bound with competent carers. For these frail patients, please complete the AMU Frailty Bundle in the CDoc within 24 hours of admission. It will prompt you to think about confusion, constipation, polypharmacy, and care status. Do discuss care status and offer ACP for patients with poor premorbid conditions and/or one or more irreversible organ dysfunctions, such as severe ischemic valvular heart disease or EF less than 20%, lung disease like stage 4 COPD, ESRF not for dialysis, advanced cirrhosis not for transplant, advanced neurocognitive disorders, and metastatic cancer on best supportive care. For disposition, during morning rounds, identify patients who are KIV home today. These patients usually require urgent input from Allied Health and are highlighted with an orange heart. Hang these cards above the patient's bed during AM rounds to provide a visual representation to all working in the unit. Confirm prescriptions early for those identified as KIV home even before confirmation. All CDoc entries for patients in the AMU must include the AMU Care Plan template. This should be updated at every entry and changes to disposition reflected promptly. For patients staying in the AMU, write in the EDD. If they are KIV for home, write in the criteria. And once patients are fit for discharge, update the care plan promptly. This template is available on the intranet and most desktops. After morning and afternoon rounds, teams must huddle in front of the AMU progress board. This board helps communicate to Allied Health, nurses, and ward clerks about the patient's plan. For reviews, red magnets indicate urgent reviews and blue for non-urgent reviews. In the disposition column, orange is KIV home and green is home. For example, if a patient in bid 1 is KIV home, if PT clears, then after clearing, the PT changes it to a green magnet and the patient is now ready for home. The board should also be updated as rounds progress. The earlier the red magnet gets put up, the faster relevant reviews happen. Finally, AMU lodgers in the EMD should be reviewed at 11 AM and 3 PM daily for those who've been waiting for more than 2 hours. This is led by the team SR but may call on juniors to assist if the load is high. In summary, let's all work together to achieve quick diagnosis, treatment, and disposition and provide great care for our patients. AMU is fast-paced, fun, and a great learning environment. Enjoy your time with us, and thanks for watching.